everyone. I hope you're having a good afternoon. As Meg mentioned, my name is Rachel Royland. I'm a new Senior Policy Director here at Healthsperian. I come from the Center for Medicare and Medicaid Innovation. I was there for about 3 years, working in both the quality and specialty care engagement sections. So for quality, I worked on what's called their quality vertical team. And so I worked across the center to help different models develop and implement their quality strategies. And then I moved over into the specialty care space, looking at how we could engage more providers in specialty care. Before I went to CMMI, I have a variety of experiences in value-based payment and quality measurement as well. And then before all my policy experience, I was a nurse and I worked in the post-acute care setting with older adults. And I did a PhD in nursing research and actually feel this feels very full circle. My PhD focused on frailty in older adults and understanding the interactions between inflammatory levels and psychological well-being in that population. And an aspect of psychological well-being was positive relationships with others. And so this feels really full circle, and I'm so excited sort of the growing attention that's being paid to sort of the importance and impact of social connections. So I'm excited to be here with you all today. As Meg mentioned, sort of my task for today is to give an overview of a new model that's coming out of the Center for Medicare and Medicaid Innovation. It's called the MAHA Elevate model. There's quite a lot of information out there on it. So I won't go into all the details. This will be more of an appetizer rather than like a full course meal. But hopefully it'll just give you enough information in case you're more interested. You can reach out to us. I'm happy to have a phone call or to just direct you to the information that's available online. But for our conversation today, I just want to give an overview of the CMS Innovation Center for those who might not be familiar with it. Go over some of their existing models just to give you some context of the type of work that they do, and then dive into the MAHA Elevate model. And then we have some time at the end for some questions if there are any. So we go to the next slide. All right, so for those who aren't familiar with the CMS Innovation Center, it's a center that's housed within the Center for Medicare and Medicaid Services. So the larger CMS, which is responsible for all the billing and other policies that come out around Medicare and Medicaid. And it's really tasked with trying to test new payment and delivery models that can help us improve patient care, lower costs, and better align the various incentives within the system to provide more patient or person-centered is really the language we're preferring to use now, practices within the healthcare system. It's traditionally focused on very much sort of the four walls of the healthcare system, but more and more it's starting to break out of that and try to look at how to better support sort of better interactions between the healthcare system and sort of the social care system through community organizations and the like. And so I think you'll see that come out in some of the models that they are starting to implement and some of the work that they're trying to promote. And I also have listed on here as the strategic direction of the center. It's very common when there's a change of administration for them to do sort of a strategic refresh to say, you know, these are what the center's priorities are going to be under this administration. And so they have a lovely figure here that they've created to try to give a visual around that. And really they're have tied a lot of their strategic work to the MAHA movement in general. So in general, just trying to help folks build healthier lives. And sort of a guiding principle of their work in trying to achieve that mission is to also protect federal taxpayer dollars. I think we all are aware of the ever increasing costs of healthcare in the country, and we want to try to make sure we're being responsible with taxpayer dollars and protecting the Medicare Trust Fund and other sources of funding that support a lot of people in this country. And so they're really tagging that as an important guiding principle in their work. And sort of the three key pillars of their work that they're driving a lot of their models under are around promoting evidence-based prevention. They're very interested in trying to take more of a health first approach rather than a health care first approach. And so trying to prevent people from eventually needing to go into the hospital or sort of developing chronic conditions like diabetes and hypertension. How can we move things further upstream? They're also interested in empowering people to achieve their health goals. And this is really around a lot of increased use of technology to try to give people information about their own health so they can be informed healthcare consumers and hopefully be better advocates for themselves when they have interactions with the healthcare system. And then they're also interested in driving choice and competition to address concerns around increasing consolidation and decreased choice that a lot of individuals have when they're trying to seek healthcare services. So this is just to give you an overview of sort of what the center generally tries to do and what under this administration their specific goals, overarching goals are for their work. Next slide, please. All right, and then here's just an overview of the most recent set of models that they've announced. I won't go through all of them, but I think one, it shows you they've been very busy in announcing a lot of models. They're very serious about trying to implement a lot of work to try to help them achieve their goals underneath those three strategic pillars that I just went over. And they touch on a very sort of various parts of the healthcare system, whether that be through primary care, through trying to promote more engagement with accountable care organizations. Um, under the lead model, trying to promote more use of tech-enabled platforms and devices through care through the access model. They're also trying to address prescription drug costs, and again, sort of embedding greater use of technology within the healthcare system through programs like Wiser. But what we're here to talk about today is the MAHA Elevate model. And Meg, I think I put an animation in if you want to click enter again. MAHA Elevate is sort of the third column list or third row listed there, excuse me. And this is a really interesting model. Usually their models focus on, how do we change payment to a primary care provider? How do we change sort of the requirements of sharing information between health systems and providers in different systems? The MAHA Elevate model is really more of like a research model where they're trying to test um, services that are not generally covered under Medicare and trying to develop the evidence base for those services so that they could possibly use that evidence to make changes to their coverage determinations. And so maybe there's a service related to physical activity that is really great. It's a falls prevention program that has shown to like have great outcomes in preventing falls, but for whatever reason, it's not a service that's traditionally covered under Medicare. They're trying to use this model to sort of build up the evidence base around those types of services so that they can perhaps start considering how they might be able to move those into Medicare at some point in the future. And so a lot of the work that they're interested in under MAHA Elevate is really around this lifestyle medicine. And that's where sort of I think the connection to this group comes in, is that one part of that framework that they're using is related to social connections. And so if we want to go to the next slide. You'll see here that the framework that they're using is the 6 pillars of lifestyle medicine. This is from an organization, a professional organization of lifestyle medicine practitioners, and they have a sort of a 6 pillar framework that helps them guide their recommendations to help people improve their functioning and improve their lifestyle and hopefully prevent chronic conditions. And you'll see those 6 pillars are around optimal nutrition, physical activity, restorative sleep, stress management, connectedness, and then risky substance avoidance. And that connectedness piece is really focused around a lot of the topics that you all focus your work around, is how do we connect people across generations? How do we help people who are socially isolated develop and sustain connections? And so they're really interested in interventions that might specifically focus on that and promoting social connectedness, or perhaps they might be looking at nutritional interventions, or an easier example, I guess, would be a physical activity intervention that involves sort of group activity, looking at, that might be the intervention, but one of the ways it's impacting positive outcomes is through enhancing social connectedness. So this is the framework that they're using to identify interventions that they would try to fund under this initiative, and social connectedness is kind of imbued throughout it, I think. So next slide. And so I've kind of already gone over this a little bit, but this is an overview of the model. And they have a really, really informative webcast that they did about a week and a half ago that gives a really nice overview of the model and the application process. And we've included the link in the slide there. But really, like as I mentioned before, they're really trying to test these whole person functional or life medicine interventions, and really focusing on how they can be used to prevent chronic disease or further progression of chronic diseases or deteriorations in physical and mental functioning. And they really see this as being part of their sort of whole person strategy to try to, again, make our system more focused on promoting health rather than just being reactive and addressing disease and other issues as they come up. How do we move our work upstream? And these interventions should be a key part of that. And so what's going to happen is they're going to welcome people to apply, and they will select between 2 cohorts 30 applications that will receive funding to test these interventions. And have the opportunity to show impact on outcomes and potentially cost savings to Medicare as well. And so the outcomes they have listed on the bottom here are really focused around trying to engage beneficiaries in Medicare into more of these lifestyle medicine interventions, trying to collect actionable data, again, like I mentioned, to build up an evidence base around these interventions and to eventually more in the long term potentially inform future Medicare coverage decisions and hopefully much further downstream improve outcomes and save costs to Medicare as well. Next slide. And here's just an overview of the timeline. For this first cohort 1, the letters of intent were due on April 10th, so that was last Friday, and the full applications will be due on May 5th, and the first cohort will be selected sometime in October of 2026. I know we're talking to you past the LOI due date, but there is going to be a second cohort, and they will be invited to apply, or the portal will be open for application sometime in 2027, so there will be another opportunity to apply in 2027 as well. So the train hasn't left the station fully for anyone who's interested in participating. There's still another option. But I think we're very excited about this model and seeing what types of folks try to apply. Would love to hear if anyone on this call is familiar with the model, if they're thinking about applying. But we just wanted to highlight it for you because we think it's a really interesting opportunity and support at the federal level for work that is very close to the work that you all do as well. And wanted to raise it for your awareness and happy to answer any questions or hear from folks about work they might be doing related to this model.
Rachel, thank you so much. That was really great, really helpful and informative, and would open it up to see if there's any quick questions for Rachel. We'll also, Rachel, maybe you can put your email in the chat here and folks can reach out if there are things they'd like to follow up on. Oh yeah, Scott, go ahead, please.
Thank you. And thank you, Rachel, for that presentation. I'm curious how the Elevate model is differentiating itself from existing coverage of health behavior assessment and intervention services, because it seems like there's a lot of overlap going on there or potentially going on there. We have psychologists who work in integrated care practices, and there are obviously other behavioral health providers that do that as well. And I think a lot of the types of work that would fall under the category of the things that were on the slides that you shared, they would argue, yeah, we do that in primary care and integrated care for a lot of our patients.
No, that's a great question. I think it might be the approach they're trying to take is perhaps widen it out to even more Medicare beneficiaries that might not, for whatever reason, have access to those services through those types of providers that you're mentioning. But I think that's a really great question, and I'd love to chat with you further about it to better understand the nuances there. But I think it's better. I think they're really trying to just, one, build the evidence base for a wider set of Medicare beneficiaries and build off of and add that to whatever evidence might exist from existing covered services to really try to take a more comprehensive approach to trying to build out their coverage determinations and hopefully make these types of interventions more available to more Medicare beneficiaries.
So is one of the assumptions that the beneficiaries that would be the recipients of whatever services an Elevate model applicant is delivering do not necessarily have a diagnosis yet for anything in particular?
I think that'll be, so what's a little bit tricky about this particular model is that it doesn't have sort of a cross-cutting set of inclusion or exclusion criteria. It's going to be on a sort of study by study basis, or so for applicants, they will determine like what their specific sample will look like and whether or not they have a specific diagnosis. So perhaps there's someone that is interested in implementing like a cognitive functioning intervention. They will list out sort of like whether or not they want to recruit individuals who have a diagnosis of mild cognitive impairment, or perhaps it's a full-blown dementia diagnosis. So there isn't sort of a specific group with a specific diagnosis they're trying to target right now. They're trying to sort of leave that up to the folks who'll be applying to say, this is the population where we think that this intervention will be most effective, and then work from there to try to work with CMS to sort of further define like the sample size, where they're going to be recruiting people from, and so forth. So it's a broad sort of umbrella type of funding opportunity that is really going to be on the part of the people who apply to sort of define who they're interested in within the beneficiary population, and then they'll work with Medicare from there to sort of define their sample size and so on. Does that answer your question?
Yes.
Uh,
I'll send you an email.
it's
It'd
a
be great
very
to talk
unusual,
more.
sorry, it's a very unique design for them, I will say. It's very broad in its reach. And it's going to be a lot, whoever does apply and is accepted, they're going to be working very closely with CMS to really put sort of to bring the test into focus in terms of who's eligible, who will be recruited, what the outcomes are, what the sample size is. It's a very sort of partnership intense kind of model.
Okay, thank you.